everyone. So, CME number 952. This decade is touted to be the decade for obesity management with multiple drugs in the pipeline. We have the GLP-1 agonist, we are looking at dual agonist, we are going to have triple agonist, plus multiple other drugs. And they have humongous benefits across the cardiovascular spectrum in obesity, Mathur, PCOS syndrome. We are looking at sleep apnea, we are looking at depression, we are looking at maybe even decrease in cancers, increasing in the pulmonary, betterment of pulmonary physiology. So there's a whole spectrum of benefits that we are looking at. And none better than Dr. Mithal sir, who has already been introduced to talk about it. His credentials have already been talked about by Dr. Chauhan and in the multiple introduction that we had. Suffice it to say, sir is the first DM endo from AIMS. He is a legend in endocrinology. What people otherwise don't know, also he has more body of work in osteoporosis, if I may say so, sir. He has published a book on this for the GLP agonist and the weight loss therapies that we are looking at. And also he is a very, very avid photographer. So it's good to follow his post, and it's wonderful to see his post very keen on clicking during his morning walk. Also, we were talking to Mohan sir, and I was just talking to sir that their diet schedules and their work schedules overlap so much, and sir is so busy but still takes time out for all of us. And he is my go-to man personally. Whenever I am stuck, I just send him a message. I know I am not going to ask him to pick up my phone, maybe sometimes in an emergency, but he always reverts back and solves my problem. So without wasting any more time, I'll not stop Mithal sir from talking to you, and over to Mithal sir for his deliberation. Thank you very much, sir.
Thank you very much. Thank you very much. It's a pleasure to be back here. It must be my fourth round here, I guess. It's like coming home every time. And since I moved to Max Saket, it really is very close.
Thank you, sir.
And it's very nice to be here amongst friends. For me, that is as much the attraction. But also the fact that this is a very keen audience, although not necessarily specialists, but amazing insights and incisive questioning. So it's great fun to discuss topics of clinical interest here. So I'll be today talking about obesity care with semaglutide. So I'm not going to focus too much on the diabetes part of it. So just to put things in perspective, before we start, you know where this is? This photograph, where is it from? It's very close actually. Saket. This is the oldest ruin in Delhi. This is the oldest ruin. In the Kila Rai Pithora Park, next to the Kutub golf course is many of you. These are the oldest ruins. This is somewhere in the Anand Tumar Prithviraj Chauhan period, just before it all changed. But this is, and there is a merger of the Jahanpana wall and this wall. Third city and first city of Delhi. So just these ruins are left, but it's a good place to walk. The park has become very nice now, as compared to 5 years ago. Yeah.
The course also.
So we'll talk about obesity care today. So we're not talking about diabetes. And as I said, the first thing we need to understand is the most common sentence here is ekdam nayi dawaiyan hai when we talk about obesity care. GLP-1 agonists have been in use for 20 years. In my clinical use for 20 years, 19 years maybe. And it started off with a drug called exenatide Byetta. Then it became liraglutide or Victoza. Then dulaglutide or Trulicity. And then there were others also which didn't sort of make the mark so much. But the fact is that these drugs have been there. Why are GLP-1 drugs great? Because GLP-1 drugs, they act through the GLP-1 mechanism. You know that GLP-1 is an incretin, which means it's a hormone secreted by the gut and it goes to the pancreas. It stimulates insulin and suppresses glucose, which means that when you eat something, it's released from the gut. As your sugar goes up, it stimulates pancreatic insulin and corrects the rise in glucose. That is the primary action. What was learned gradually was that this drug is not just doing the gut and pancreas loop, it's going into the blood. This molecule, and it actually goes to the brain. And it tells us to stop eating. Right? So GLP-1 molecule tells us to stop eating. It controls the satiety. I'm not going to give you a look, but just this much is enough for us in general to remember. Now, the thing in this is that people thought of this a long time back. GLP-1 को दे देते, तो कंट्रोल हो जाएगा, शुगर कम होना चाहिए, कंट्रोल होना चाहिए, भाई इंसुलिन सिक्रीशन करेगा, ग्लूकागॉन सप्रेस करेगा, खाने को भी रोकेगा. What was the problem? Problem is you give GLP-1 intravenous, two things happen. Number one, it gets broken down in 2 to 3 minutes. So you have to give a continuous infusion to get any benefit. Second is the moment you try to increase the rate, people start vomiting. So then for decades, 2 decades almost, it was on the back burner, or at least 15 years. ये कुछ हो नहीं सकता है. It's not an area where you can do that much. Before I understand some fellow came up with the idea, why don't we just give very small doses first and then build it up. And that's how people realize that when you build it up with small doses, then it doesn't produce those kind of GI side effects. That is one part. At a deeper level, the science was able to make molecules that resisted that breakdown in 2-3 minutes. Right? And the first of those are Obesity, which is from the Gila monster, but we are not going there. But the fact is that we were able to develop either through nature, found in nature, or develop in the laboratory, molecules that resist that breakdown of GLP-1. So when you give it from outside, then it stays in the blood, it does the work that you want it to do. This is how GLP-1 drugs came. Now, one of the positives of the GLP-1 drugs was that they promoted weight loss. Now, for a long time it was thought that because they slow gastric emptying, they produce GI side effects, that's why people lose a few kilograms. With all the earlier drugs, you lost 3-4 kilograms, right? The odd case may have lost anything, but this is how it was. What changed with the advent of semaglutide, why is it called the Ozempic revolution, and all those things. For the first time in history of mankind, you had a drug that could cause more than 15% of body weight loss. So your baseline weight is 100, you could come down to 80, 82, 83. This is not seen before. And we all know that 10% weight loss can have huge biological benefits. So that is why semaglutide is considered a breakthrough. And actually it has opened up a channel for a whole plethora of drugs that are going to be here one after the other in the next few years. It's quite incredible, which is why I agree that this is actually a revolution. I'll explain more why I think that these drugs will change the way medicine is practiced. I think, someone asked me, what would you compare it with? I think definitely it's a statin moment. I don't think it's an insulin moment. Insulin is life-saving and nothing can match that. But I do think it is a statin moment. Now, unless some rare side effect appears 20 years down the line, and by that time we'll have 20 new molecules also, I do think that this is actually a revolution. It's not humbug, it's not all media hype, it is not all industry push. There is evidence for us to see in literature how amazing this whole set of drugs is. And if they can, over a period of time, reduce the side effects, improve the tolerability, I think you will have a winner on your hands. So there are challenges in everything. But the fact is that in principle, in concept, these are game changers. Nobody can deny that. So today we'll talk about obesity. So we have to go through the rituals of a few slides. You all know, because the audience knows that obesity is very common in India. When we were kids, obesity was not common in India at all. But now we know the recent data, if you take a BMI of 25 as cut off, then 1/4 almost of women and men are obese. I mean, that is huge. 1/4. There's no other disease like that. And you also know, way back in 1997, WHO classified obesity as a disease. Now, I'm a little reluctant, this is a personal thing, to call it a disease because that means sabhi ko bimari, everyone feels sick. Ab sabko bol rahe ho disease, sab bimar hai. Sab sochenge I'm sick, you know. So at least a condition that requires attention, that can have serious implications, whether you think of it as a disease or not. The advantage of thinking of it as a disease is then you think of treating it with medication also. The disadvantage is that it can depress some people. If people at BMI of 26 are called disease, then that's a big problem, I mean for psychologically. So for medical terminology, it's fine to call it a disease. For patients, it's not a great idea to tell everyone that you've got a disease. I don't think it's a, as someone who manages patients morning till night, everyone who walks into my OPD then has a disease in addition to his primary disease. Hardly anyone I see below BMI of 25. Thyroid hai to, menopausal symptoms hai to, kuch bhi hai. At least 80 to 90% will be a BMI of about 25. So what I'm saying is that we recognize it as a disease, it requires attention, but just an aside, I don't think I tell my patient that we have a disease. I just say your weight requires attention and then you'll get into a lot of problems. So anyway, so this increase in obesity has been rapid. Certain reasons, no surprises. I mean, Punjab will be high in obesity, there's absolutely no doubt. I'm sure it will be higher than Bihar, for sure. But the fact is that there is a dramatic rise. This 5.21% is the overall obesity rate based on Western obesity criteria, 30 BMI. You look at 25, then it is 20. If you look at 25 BMI, then almost 1/4 are. And if you look at abdominal obesity alone, which we know is the trigger for everything, it's 45%. So imagine the bomb we are sitting on. Why sitting on? It's actually exploding right now. And remember that obesity is the mother of all modern non-communicable disease. And the diabetes epidemic is fueled by obesity. If you took away theoretically all the obesity in a particular population, type 2 diabetes would almost go. You'll be left with 5 to 10% of type 2 diabetes. It will finish. Now obesity here also, remember that it does not just mean what we see as obese, it also means visceral fat, which is particularly important in Indians, which is why again a rather difficult definition of redefining normal range for Indians, meaning that Indians develop metabolic complications at a lower body mass index. Okay? Lower body mass index. So what the West develops at 25, we develop at 23. What the West develops at 30, maybe we start developing at 27, 28. So there are issues. Why is that? Because for every given amount of fat that we have a higher proportion which is around our viscera, or internal fat, or central fat, or visceral fat, whatever you call it. And that fat is the one that produces all the damage. The fat that is inside our tummies, or even deep subcutaneous fat, some studies have shown, it produces bad toxins, which produce inflammation, which damage our pancreas, our heart, free fatty acid. I mean, there's a whole cycle there, we again won't go there. But the fact is that visceral fat is the bad fat. Not all fat is the same. And Indians have a tendency to deposit visceral fat, right? South Asians, not just Indians. So therefore, if you revise the criteria for, if you adjust the BMI, it will keep coming down. Even at very low BMI, the Indians have higher visceral fat. But it's not one thing, you know, what determines our body weight, and that's very important in a practical sense. In a practical sense, there are multiple factors. Even us as physicians, and some of you will bear me out, when you saw an obese patient in the OPD, you would also khata bahut hai yaar, isko kya kare? You know, itni baar samjha chuke ab khayega to then he'll face the consequences, you know. So that is a small part. Discipline is very important. The change in obesity is linked to our change in eating habits. But the truth is it's much more than that. You can't blame always the individual for the obesity. That's not necessarily correct. There are biological factors there, the in utero environment, amazing studies have shown both maternal malnutrition and maternal overnutrition, like obesity, can have a program the fetus in a way that the baby will put on more weight moment it's out of the tummy, moment exposed to more energy-rich food. Gender, genes of course, then environment, which is what has changed in India. That's food availability, social determinants, environment around us, availability of healthy options. This is my constant refrain. I was asked the other day on television that I got suddenly this question out of the blue that, so okay doctor, rapid fire, if you had one advice to give to the government about tackling this epidemic, what would you do as a policy? I said, healthy foods should be cheaper than unhealthy. That is the only way you will get people to move towards that. Milk should be cheaper than Coke. Example. So that as policy, governments have to work towards this. Otherwise you may give gyan to everybody, but you know, if the economics doesn't work that way, people will just do that. They will do what they were doing. So just saying that environment matters a great deal. Personal awareness, family awareness. I have these patients where the whole family is significantly obese, but one person develops diabetes, and the whole family, including the kids and the spouse, attacking that poor chap for, you know, कि खाते मीठा खाते करते सबका weight वही सबको हो जाएगी diabetes, लेकिन वो target है उस समय. So there's a problem in that. There's societal, like what is expected, what do people enjoy, acceptability. So all those things are there. School food is a big challenge. Youngsters' food. I have to go for media interviews very often. What do these people eat at work? Is whatever they order, which is easily available, whether Indian or Western. Another myth we love to say, हमारा Indian food बड़ा अच्छा है. सब गड़बड़ तो ये सब American chains ने करी है आगे. So no one can deny कि उन chains ने गड़बड़ करी है, लेकिन हमारा Indian food कुछ मतलब आज समोसे कचौड़ी खाएंगे तो कहाँ से वेट मतलब obesity tackle करेंगे? So the fact is that we love to, as Indians, we love to transfer the blame, deflect the thing on somebody else. Doctor खराब था, अस्पताल खराब था, ये खराब था, वो खराब था. या वाइफ ही खाना ऐसे देती मैं क्या करूँ या खाना ऐसे कुछ मतलब मैंने कुछ नहीं किया. इसीलिए वो खाना भी बाहर से ले आए लोग क्या करें कोक पेप्सी ऐसे वो रहते हैं. ये नहीं कोई बोलता कि समोसे खाता हूँ 4 रोज. तो issue is that there is a psychological barrier in accepting responsibility for our condition. Should be there. So I think behavior changes are very important in obesity. Really, if we have to tackle this epidemic, it cannot be done by just single कि आपको ज्ञान देना, मतलब आप अपने पेशेंट को ज्ञान देना. It has to be by the overall environment changing and the options changing. So it's not just fat. It's about inflammation. More and more focus on inflammation that visceral fat produces. Weight gain, adiposity, and inflammations that cause a decline in metabolic health. We know that insulin resistance is the key that starts all this. Dyslipidemia, again inflammation everywhere, and liver. So, okay, when we think of diabetes, traditionally with the blood sugar doctor बोलते थे हम लोग एक time पे. When diabetes was in endocrinology, actually a very small part at that point. I'm talking 30-40 years ago. It was more of thyroid and complex gonadal problems. But diabetes जैसे बढ़ा तो सब वो sugar doctor. पूरे एम्स में 1984 में 2 ग्लूकोमीटर थे. इतने बड़े. एक रहता था उसमें रेजिडेंट एंडोक्रिनोलॉजी के पास, सीनियर रेजिडेंट was the big boss of the whole hospital. Because किसी को blood sugar कराना होता था तो वो you had to contact the senior resident endocrinology. Just saying. So things have changed, but the fact is that we now recognize that if you want to manage diabetes well, you can't do it as just blood glucose. That's the point I'm making. You have to manage, it's become very complex. The truth is, if you're really going to give good care to a diabetes patient, it is like most comprehensive that you can think of for all of you physicians, chronic care physicians. Because if you're managing diabetes, of course you're managing blood glucose, you're managing weight. Very, very important to manage the weight for other things. You're managing hypertension, you're managing dyslipidemia, you're managing, if there is some thyroid or something, whatever, you're managing vitamin D, you're managing B12, all those things you're managing. Plus, you're looking at the CGM patterns and all those things now these days with the continuous glucose monitors, etc. Plus, you're looking at liver health. Right. So many of our patients have MASLD and they require fibroscan, weight. And then if you have a crazy man like me who also gets bone density done for everyone over 60, half of them turn out to have osteoporosis. So you have to deal with that also. So every patient head to toe is a lot of work, painful work actually at times because because of the number of people waiting and all of it. But you don't compromise. So what the point I'm trying to make is that if you're a diabetologist or a physician managing diabetes, you have to manage the patient holistically. Please do not think that A1C is good, the patient is fine. I think that's a very, very important thing. The more relevant for endocrinologists, but I thought I'll say it here. Now, when we look at different stages of weight, there are different levels of complications. Again, you will know this. BMI less than 25, nothing. You just do lifestyle, obviously. Then, the moment you reach higher, you are looking at more and more things. You have to look for liver, you have to look for sleep apnea. I mean, all those things. And you might start requiring medication. And the orange and the red means you do require medication. Which means that a very high proportion of people who are overweight or obese actually do require medication. So what is the indication in India? Approved for GLP-1s for weight loss. A BMI over 30 even without comorbidities. And a BMI of 27 to 30 with comorbidities. So if tomorrow you go and check in your OPD, what proportion of patients fulfill, they have come for something else. What proportion of patients fulfill the criteria, you will find a very, very high proportion. And ultimately you think कि क्या सबको GLP-1 देना चाहिए क्या? So एक दिन ऐसा हो सकता है आए, unless कोई side effect निकले टेढ़ा मेढ़ा. But it is actually eligibility criteria. I asked my resident, यार सभी लग रहे हैं इसको भी देना चाहिए, इसको कैसे decide करें? तो हमने थोड़ा अपना कुछ बना लिया है. But what I'm saying is, if you look at it like that, everyone who comes to you, most of them would be candidates for GLP-1 because they all require weight reduction, they all require diabetes management or lowering of glucose, lowering of visceral fat, improvement in fatty liver, regression, most important, and I'll come to that at the end, of other organ complications. So GLP-1 RAs have effects on different organs. As I said, started with the pancreas and gut. Pancreas, most important, you know that. Gut, slowing of gut movement, especially stomach movement. Liver, again, it has direct actions, without going into details. Direct effect on the heart also, especially vascular system. And very interestingly, the major focus of interest effects on the brain. Because it acts on the brain, right, to control your satiety. But those effects, the neuroprotective effects, the neuro-anti-inflammatory effects of GLP-1 are absolutely fascinating. And the most important trials, if you ask me right now, are the ones on Alzheimer's. They are not complete yet. But if it turns out to be right, that it reduces cognitive dysfunction, development, and reduces risk of Alzheimer's, I mean, that will be absolutely amazing. So, absolutely. So, different kinds of... So, the thing is that the fact that they are able to reduce inflammation in the brain. So, what I'm saying is that just think of the, things you're doing with one set of molecules. You're doing so many things. But, the reason I'm showing this here is because this is an old slide actually, a couple of years old. But this was important because we all, including me, 15 years ago thought, oh, gut motility kam ho jati hai, to bhook kahan se lagegi? But then it was realized that it is a brain effect. The nausea, vomiting, as well as weight reduction or reduction in appetite is a brain effect. Obesity is a disease of the brain in most cases. Unless you address that, you will be doing only, window dressing. So, human studies have confirmed obese patients have fewer food cravings when treated with semaglutide. Sugar cravings showed a dramatic reduction, right? The problem is the next slide. So this is not universal. Huh? We learned by experience. We have now what? If you include tirzepatide, easily more than 600 patients. I just this morning took out the number of patients on Wegovy, which is recent, so there are less. But if you include tirzepatide was launched first in India, so we have like 600 patients. So there is huge variability in response. Huge variability. As said, some people develop aversion, but some people have no difference in their taste of food. So this is strange, but this is how it happens. Anyway, having said that, one of my patients, not one, several of my patients have complained about the last point here. That बोले खाने का मजा ही खत्म हो गया. What is there left in life? जिंदगी भर डॉक्टर साहब मुझे पराठे पकौड़ी का इतना शौक था, मुझे अग्रवाल साहब ने बोला इतना शौक था और मुझे अच्छा नहीं लगता, पता नहीं क्या हो गया. मुझे देख के चिढ़ मचती है, देख के चिढ़ मचती है. और उसके अलावा ये तो बोले साहब जीने से फायदा क्या, तो मजा ही खत्म हो गया. Then there was enough evidence to show that only in responders does the brain light up. So wherever it goes to the right place, there it produces the effects. Another very interesting effect, a conversation with this can happen only in Delhi perhaps. As a patient said, मैंने कहा सब बढ़िया हो गया आपका, तो आपके 11 किलो वजन कम हो गया, शुगर एकदम कंट्रोल्ड है. बोले क्या है साहब, यार दोस्तों ने सब ने मुझे बाइकआउट कर दिया. क्या हुआ? बोले साहब वो अल्कोहल देख के एकदम नफरत होती है मुझे, मेरी शाम ही खराब हो गई. अब लोग आते हैं, मैं कहता हूँ मैं नहीं पीऊंगा, क्यों नहीं पीऊंगा, तो एक ग्लास. Aversion to alcohol, there are trials ongoing for that. Aversion to alcohol, so maybe that is also found in some cases, but definitely some patients say this. Yeah, I just cannot tolerate the sight of alcohol, it irritates me like. So, you know, those kind of behavioral things happen. So, we started in India first with oral sema, you know that. India was the only country perhaps where oral sema was launched first. Why is that a big thing? Any drug that can go from injectable to oral is a big thing. For peptides like semaglutide was unheard of. But Novo Nordisk was able to develop technology called SNAC technology. That's not the topic today. But that allowed absorption of this peptide. So जो ribelsis करके आप लोग use करते हैं, that is oral semaglutide. Which before that no one could have this group of drugs absorbed. So they launched that in India first. And the truth is that we are big users of that. These are data of the first 500 patients anyway. But the average weight loss is here. 4 kg. I mean, there are patients who have lost 15 kg, but the average weight loss is 4 or 5 kg. You know, that's all. We were using it primarily for diabetes management. It compared very well with real-world studies. We published this earlier this year, the initial experience with oral semaglutide. So the idea is that we have our hands, we were fairly comfortable with our hands-on experience with oral semaglutide by the time the injectable preparation came into the market. Same drug, same molecule. Ribelsis is equal to Ozempic is equal to Wegovy. It is exactly the same drug. So don't let anyone confuse you. Companies will confuse you a lot sometimes. The same molecule. Ribelsis is a lower dose oral Ozempic. Okay? Wegovy is a higher dose injectable Ozempic. वही है सब Ozempic ही है. वो उनके रेगुलेशन के लिए, अप्रूवल्स के लिए US FDA से वो Wegovy को ओबेसिटी के लिए कर दिया और Ozempic को diabetes के लिए कर दिया, for whatever reason. So we had good experience with oral sema. But this is the classic, the stepping word comes from this. I will not go into details of any study today. I don't want to bore you with studies, just the essence of what we have to say. Simple weight management in the STEP study. Look at the percentage weight loss. 15, the pink bars obviously is semaglutide versus placebo 2.4, right? Now, in diabetes, you notice the difference here? Moment you use a drug in diabetes, that 15% often becomes 12%, 11%, 10% also. तो पहली बात ये याद रखना है कि जो हम 20% ज़्यादा weight loss सोच रहे हैं tirzepatide से या 18% सोच रहे हैं semaglutide से, उसमें डायबिटिक्स में 5-7% कम हो जाएगा on an average. People 17.4% weight loss. So you hadn't seen that. I hadn't seen that before. I'm sure you had no drug that could cause this kind of weight loss. So this weight reduction, I think, was very, very important to understand that in the obesity studies, this was the first in-class drug to produce more than 15% weight loss, which is why Ozempic became the name of the whole group, which is now much more than Ozempic. But you know, that's how it's called, because that's what it was the first. This is, all these are using 2.4 milligrams semaglutide. Just to put 2.4 milligrams subcutaneously once a week, injected. Important to put in perspective that why not use oral? Oral में तो वही है, same drug है. But oral में जो approved है 3, 7 and 14, that is maximally able to achieve the levels equal to 1 milligram weekly of semaglutide. अगर आप maximum भी oral देंगे तो आप middle of semaglutide doses में रहेंगे, जो actual obesity doses पहुँचते नहीं उसपे. So now what is Novo doing? They have tried 25 and 50 milligram oral, and they have found results of more than 10% weight loss. I suspect that will be launched sometime in the future.
As good as 2.4 Sema.
Almost.
50 milligrams.
Almost.
Evoke trial, sir.
So yeah, so 25 milligram will probably possibly be marketed, but there is a challenge there. What is the challenge? The amount of drug required is so much that whether they'll be able to maintain the supplies is not clear. So Lilly is coming with orogriflon, that's separate. But what I am saying is that it is just the amount of drug delivered that is the difference. If you can deliver the same amount of drug using oral as you do with injectable, then it's the same thing, right? On the other hand, with semaglutide, what is happening is that they have gone to 7.2 in trials. 2.4 heavy, 7.2 says or weight loss. So the whole field is dynamic, and there will not be a week, not 1 week, where you won't find some interesting, totally new information on these group of molecules. So this is just today, as of 10th September. After the drug was launched, I'm very open about my data, and there's nothing. We have 114 patients on Wegovy, out of which 79 were just started straight, but 35 graduated from oral dialysis. Meaning what? कि dialysis 14 milligram ले रहे हैं, आगे अटक गया मामला, क्या करें? So then you move them to Wegovy injectable. I find that very smooth way of doing things. If someone is not able to achieve optimum weight loss, which you often are not with dialysis, tolerability has been tested nicely till 14 milligrams, then you can transition to 1 or even 1.7 straight away. So that's one group. You can see almost half of those are in that group, but not half of the total, but 35 out of 114, 1/3 you can say approximately. And otherwise started safe. Then there were others who had used oral GLP-1 in the past, not oral, injectable GLP-1 in the past. And out of the patients so far that we have used it on, again, surprisingly 79 is the figure again, about 70% have diabetes and 30% don't have diabetes, right? Now, there is no set criterion whether it should be used for diabetes, less, more, whatever, but we'll talk about that a little bit. So, we can leave this, everything is required. I'll show you 4 examples that came to my mind, and I dug out their paper, but I just put 1 line each to just show the variability in all these things. 58-year-old female with no history of diabetes, 114 kg, reached 92 in 6 months, now on 1.7 milligrams. 6 months, how we can say? Because the patient is procuring it from outside earlier and then transitioned to Wegovy when it became available. So, isn't that fantastic? Now, this person, it's only 4 weeks, but she's totally frustrated. There is no weight, not even an ounce of weight loss with 1.7 milligrams sema. the second patient, who was on insulin and multiple other anti-diabetic drugs, so she'll be a tough nut. What I'm finding is that we shouldn't give up hope quickly. Many patients, when we persist and when we reach the highest dose, they do respond. So if you read the book, there are stories of people who didn't respond at all, right? Or very poor response. But the same patients now, it's 3-4 months after the book manuscript was given in, some of them have responded with sustained effort. But still, there will be overall 10% people who don't respond very well in terms of weight, which means less than 5% weight loss is considered non-responders. So there will be almost 10% who are like that, if you especially include diabetes and non-diabetes. Just an idea for A1C. The A1C responses are actually overall quite amazing. Even in oral sema, most of our patients are below 70. That is quite amazing how rapidly it happened. Look at this, 12 to 7 on just 1 milligram injectable. The other one, of course, lost weight, but there was no change in A1C, but there is a catch there, it's written like that. That actually, the baseline A1C was 6.4. You know, by the time we started, she was 6.7, had come down to 6.4 with lifestyle. So ज़्यादा कुछ हुआ नहीं, तो वो ठीक है. But if you ask my impression, by and large, A1C reduction is dramatic. It's really, really good, amazing. Underscoring the fact that much of type 2 diabetes is actually related to what we are eating and how much food we eat. Right? Now, I'm not going to go into all the side effects, but you all know about gastrointestinal side effects. That is the main limiting factor in their use. If you ask me the three limiting factors, most important is GI side effects, then is cost, and third is injectable, of course. But injectable, once again, is very easy for patients. So the main are the cost and the GI side effects. So GI side effects, and I'll describe them a little later. Muscle loss, everyone says very muscle khatam ho jayegi. Muscle loss bahut ho raha hai usse, bahut ho raha hai. So what is the story of muscle loss? At the moment, all the evidence suggests that the muscle loss that you see with the use of these drugs is because of rapid weight loss. If you were to check the action of these drugs on muscle, they are actually favorable. So if you were to compare a cohort of people who've undergone bariatric surgery versus this with comparable weight loss or lifestyle-induced comparable weight loss, you would find that these people don't have poorer muscle mass than them. So everyone who loses weight, if you lose 10 kilograms of weight, you will lose at least 2 kilograms of muscle. That is the norm. तो इसमें ज़्यादा नहीं होता है, लेकिन क्योंकि पहली बार एक टूल आया है जिससे रैपिड वेट लॉस हो रहा है, तो लोग को दिखता है कि मसल लॉस बहुत इम्पोर्टेंट है. So we must ensure weight-bearing exercise, strength training, and adequate protein intake. It sounds very easy, but it's not easy. Because Indians, for example me, we are not used to strength training. Walking कर लिया, थोड़ा stretching, थोड़ा yoga, strength training तो मतलब पहलवानी थोड़ी करनी. तो लेकिन वो है, it is important. More and more we realize how important it is. That's one. Second is we say protein intake ये तो कर ही सकते हैं, वो non-vegetarian है. अगर आपका intake 2000 कैलोरी है और आपने दवाई शुरू करी तो intake आपका 800 कैलोरी हो जाएगा, 1000 कैलोरी. उसमें adequate protein चाहिए आपको, फिर 60 ग्राम प्रोटीन चाहिए, 70 ग्राम, 80 ग्राम प्रोटीन चाहिए, कैसे पहुँचेगा? So you require the help of a good nutritionist. Do not embark on these therapies without being clear about, diet and exercise. ये सब कहने के बाद भी 25-30% लोग स्लिप कर जाते हैं, ना न्यूट्रिशनिस्ट से मिलते, ना कुछ करते और बस खुश रहते हैं वजन कम हो रहा है. एक ने मुझे बोला कि ऐसा जब दवाई से कम हो रहा है तो आप मुझे क्यों कह रहे हैं सब करने के लिए? So then you have to sit them down and explain the reasons why you are doing that. So MTC ये सब theoretical है for medullary thyroid cancer. For precaution and in the kind of patients I practice in this vicinity, I do get a baseline calcitonin done for everybody. कोई hidden MTC वगैरह नहीं किसी का चल रहा, पता ही नहीं लगे, बाद में हो जाए. Always ask for a family history of thyroid cancer. That's very important. Pancreatitis also is a bit of a bugbear. Very little evidence that there is serious risk of pancreatitis. उतना pancreatitis तो sitagliptin से भी होता है. So तो ऐसा नहीं है, लेकिन फिर भी मैं बेसलाइन एमिलेज लाइपेज करा लेता हूँ, कोई इसका लॉजिक नहीं है बहुत, इट्स मोर टू सेव माय ओन स्किन, यू नो, बट आई डू गेट इट डन। उस इतने सब पेशेंट में 500-600 पेशेंट में एक को निकल आया, सब क्लिनिकल पेनिट्रेटिस, एमिलेज लाइपेज है, सीटी स्कैन शो नथिंग, पेशेंट है नथिंग, सीटी स्कैन शोड एविडेंस ऑफ माइल्ड पैंक्रेटाइटिस, कम से कम आई डिडंट गिव दैट पेशेंट GLP-1 है, बाद में होता तो समझ नहीं आया क्या हो रहा है, ऑल हैव गॉन ऑन द ड्रग। सो ये तो कुछ खास बात नहीं है, और ये ड्रग, ये रिस्क तो विक्टोजा के साथ भी थे, टूरिसिटी के साथ भी रहते हैं, वो तो है। The last one is the one that is the only side effect which is yet unproven, but which is creating a bit of, you know, stress, I would say, but it's quite unproven yet, and you have to realize it's very, very risky, a very, very low risk, very rare. Not risky is the wrong word. It's a risk that is, if at all it is proven, is still very rare. That is, one is, of course, we know whenever there is rapid control of diabetes, you can worsen proliferative retinopathy. तो इंसुलिन से भी होता है। अगर किसी के 11 ब्लड हो A1C, आप उसको 1 महीने में ले आए 6 पे और इंसुलिन इन्फ्यूजन लगा के, तो वर्सनिंग ऑफ एग्जिस्टिंग proliferative retinopathy. But there have been some, these are not really longitudinal trial type of studies, but observational studies which have suggested that age-related macular degeneration of the wet type can worsen. And there have been also a few reports of a condition called NION. If there are any ophthalmologists, they would know better than me. Non-arthritic ischemic optic neuropathy. Now these are very few and far between, but the fact is that there is a little flag there. And okay, so to put it in perspective, what did the study show? That in the general population, in 10,000 patients, the risk of NION was 0.02%, which means 2 people out of 10,000, right? And in those who took the cohort that were on the drug, the risk became 4 out of 10,000. So doubling of risk तो है, लेकिन absolute risk is very low. But ये अभी proven नहीं है. There are equal number of studies that show no risk at all. Every day you read a new study. So it's in the realm of discussion, debate, and actually planned studies that are ongoing, which will prospective clinical trial type pattern studies which will give us a correct answer. But पता होना चाहिए, as physicians you should all be aware कि ये चीज़ described है, किसी को है known आपके relative को या MD patient को, तो उसको क्यों देंगे? और अगर किसी को है optic nerve issues या उसमें fundoscopy में crowding दिख रहा है आपको optic nerve पे, that is one of the things that they say, crowding around the optic nerve, then they are at higher risk. Why should you use it? That's all. But once in a while किसी को अगर हो भी गया तो you cannot be at all sure at the moment कि इसकी वजह से था कि नहीं. But जो reported है वो है. ये we did a review. I'm leaving this out. Bone and Muscle published it in last year. ये भी छोड़ देंगे इसको. Now, moving on away from semaglutide, just for 2-3 minutes to bring you into sort of this thing, it moves ahead from GLP-1 to GLP-1 plus GIP. That is tirzepatide, which is also available, an amazing molecule. Again, so with the same unimolecular agonism of 2 pathways, fascinating. This is one of the best lectures I've heard in ADA ever. By Mathur last year, 23 ADA. Just incredible. He described the journey of discovery of these molecules, with the whole not being semaglutide, but how he moved ahead from semaglutide and moved differently. So एक ही molecule से 2 pathways आपने fit कर लिए. तो उसमें tirzepatide आ गया, या survodutide future के लिए. वो glucagon और GLP-1. तो GLP-1 is a constant. GLP-1 कितना कुछ नहीं होगा, उसके साथ में किसी में ग्लूकागॉन है, किसी में GIP है, to enhance effects, and that I think is a fascinating area. This is tirzepatide, as you can see, and then you're talking of triple receptor agonists. When Reta-2 tried, we are talking of 25% weight loss. You know, so fundamentally speaking, I think GLP-1 alone, semaglutide has peaked. I don't think you'll do much more with just targeting GLP-1 alone. It's going to be more and more modifications. People are using amylin agonists along with this. People are using cagrisema. I mean, all kinds of things are happening in this. So there's a lot of research on preserving muscle mass. Since rapid weight loss will become a norm or reality across the world, there's a lot of research on drugs that will preserve muscle. तो वो साथ में दे दीजिए इसके. Future ये देख सकते हैं. तो weight loss के साथ muscle loss नहीं हो. It might really work there. I mean, there's huge development. Okay, I told you about Novo's oral high-dose ribelsis. Cagrisema is another approach. There are new drugs that will be given once a week, once a month. Once a month. Once a week, once a month. Okay. Then there is another class of drugs, Maritide, which actually the effect persists after withdrawal also. So lots of things are happening there, So I think this has opened up a channel which will change the way how we look at chronic disease. It's already changing. Now, to the last practical part. So this is the approval in our country also. Right? I just mentioned that. Ideal candidate is type 2 diabetes, overweight, obese, no-brainer. No one can question. It's probably going to be lifelong. Right? As per waist circumference, waist ratio, we're not going into all that today. There are many ways of measuring obesity, but I do think that biosphygmometers will become part of most metabolic clinics. I mean, I don't think you can do without that if you're going to use obesity as treat obesity as a significant specialty. So, abdominal circumference, I've already said, we won't. I mean, the last line is important. We need to target visceral fat in the clinic and not just fall for visible fat. Right? This is again, these are not guidelines. Huh? These, from the white slides that have come, they are just what I practice. Okay, so I don't use it in frail and elderly. तो कोई बहस करने लग जाती है, why not? मैं तो नहीं दूंगा, मतलब अगर वो पहले ही फ्रेल है उसको भी दे दे, ठीक है डायबिटीज इंप्रूव होगी, आप बोलोगे आपका कार्डियक आउटकम बेटर हो जाएगा, लेकिन मतलब क्यों दोगे यार, गिर गए कुछ हो गया ऐसा क्या? पर लोग हैं हर एक्सट्रीम में घुसते हैं कि नहीं why not? So अगर हार्ट फेलियर है तो क्यों नहीं देंगे, ये है तो क्यों नहीं देंगे, बट आई वुड नॉट, मैं तो नहीं दूंगा अपने पेशेंट. अंडरवेट टाइप 2 डायबिटिक्स में भी काम तो करेंगे, बिकॉज इंसुलिन सिक्रीशन तो बढ़ाएंगे, मैं तो नहीं दे रहा. और टाइप 1 डायबिटीज मैंने दिया है, जो मेरे जो टाइप 1 डायबिटिक्स हैं उसमें एक सिग्निफिकेंट प्रोपोर्शन वो इंसुलिन एडजस्टमेंट सीख जाते हैं और खाना खा के वेट बढ़ाते जाते हैं. अच्छी खासी ओबेसिटी टाइप, हमने कभी सोचा ही नहीं था ऐसे कि टाइप 1 डायबिटीज इतने ओबीज हो सकते हैं. दे स्टार्ट विद वेरी लीन, but with insulin they eat and they know how to adjust the insulin, so they manage their diabetes. And I've been adding liraglutide also in them. Makes a dramatic difference. So you may erase this part if you like from your memory. It's not approved for type 1 diabetes, but I'm just saying that this is what I do sometimes. Now, definitely not pregnancy and lactation. No family history of medullary thyroid cancer. No history of pancreatitis. Acute proliferative diabetic retinopathy. ये थोड़ा वेग है, prone to nausea, लेकिन बहुत ज़्यादा है जिनको GI symptoms हैं उनको क्यों देंगे, आप परेशानी हो जाएंगे, आपको परेशान करेंगे. And of course, I do believe that someone who clearly has sarcopenia and very lower muscle mass, I am not so keen, even if the person is obese. You can use it. I'm not saying you can't, but I would not.
Gallbladder disease?
Not unless there is an active ongoing disease. If there is a gallstone, it's not a contraindication. But the risk of gallstones goes up with this. There is no doubt about that. With any weight loss, rapid weight loss, I should have mentioned that. With rapid weight loss, there is an increase in risk of gallstones.
After Lapcoli, it can be done.
Yeah, with anything.
Once you are removed, it's fine.
We come to the question.
So, what is the principle of management? This is what we'll be doing. That's why I'm putting these slides at the end. Start with a low dose and gradually increasing the dose. Don't get pushed by your patients. My patients are chewing up my brains all the time. जल्दी वेट लॉस करना है, शादी 3 महीने में, आप तो कह रहे हैं 3 दिन में असर आएगा, बेटी की शादी है. तो मैंने कहा आप ठीक तो है, नहीं मुझे I have to fit in my old clothes. अब ये सब मतलब बड़ा अजीब जोन में हम लोग फंस गए, इसकी आदत नहीं थी। ये सब कॉस्मेटिक वालों का था सब काम, तो इसमें हम क्या करें यार, लेकिन नहीं लोग और अपने फ्रेंड्स की वाइफ वो जान लेते एकदम, हाँ भैया मुझे नहीं पता, मुझे नहीं देते आप, ये उसको दे दिया उसको दे दिया। तो ऐसे कैसे गुजर, जब BMI आपका 25 है या 26 है, या आपको वेट इतना लूज करना है, 3 महीने में हो ही नहीं सकता ना। बट डोंट गेट पुश, स्टार्ट लो एंड गो स्लो. Okay? In fact, some people are saying you can start even lower than recommended. You can start with half dose of the starting dose sometimes. Okay? So, ठीक है, but if you go up slowly, then you'll do very well. Does this go off? Nausea and vomiting is central. So local drugs will not help too much. You need on-dem MSET kind of medication. Sometimes if there's a lot of reflux, you may need, some prokinetic along with PPI. So you use that as you would for any person who has these symptoms, right? Nothing specific. हमने एक हैंडआउट बना दिया पेशेंट्स के लिए, कौन सी दवाई कब ये हो तो क्या दवाई लेनी है. You will feel full. You must have enough fiber and drink enough water. वाटर तो ठीक है, लेकिन फाइबर और प्रोटीन, एज आई टोल्ड यू, जब इंटेक ही कम हो जाता है, इट कैन बी क्वाइट अ चैलेंज. इन माय एक्सपीरियंस विद tirzepatide, constipation is a big problem. I mean, 3 patients of mine over the last couple of years have landed up in emergency because they were so distressed by the constipation. This is all soft. This is not published data. With semaglutide, I'm finding nausea is more common. That's the trend. Both cause both, but this is the trend. Even you can get even diarrhea. Instead of constipation, then episodic diarrhea, because वो gut flora changes and थोड़ा सा भी infection होता है, थोड़ा सा भी spicy food होता है, some people get an episode of diarrhea. Eat slowly is important. Have smaller portions of food. And if you can walk for 10 minutes, 15 to 5 to 10 minutes post meal, you will reduce your risks a lot. Huge difference if you're able to do that. Okay? I can leave that. There's still a few more slides left, and you will excuse me for that. And the reason is that today was close to a disaster, because when I wanted to use the 2 new studies, which I will show very quickly, then those, when I tried to merge them with my slides, my whole presentation was going off. 3 times I lost my presentation. So now, this of course is, I'm showing off my photography. This is the what flower is this? So what common flower?
This is champa.
Champa है ना?
Yeah.
Absolutely. So from
Very
so
fragrant.
many colors, so many colors. So this is the time.
Plumeria is the other name.
Plumeria भी बोलते हैं,
Plumeria,
frangipani बोलते हैं, चंपा भी बोलते हैं.
English name, yeah. Very fragrant.
Yes, yes.
I have 3 of them, 3 colors.
Sir, is it cardiotoxic? Really? I don't think so.
Huh? What is it? What is it?
It is not a cardiotoxic.
No, who said so?
So okay, I'll take 2 minutes more, 2 minutes, because I think it's important. This is not about weight alone, not about diabetes alone. This is also about cardiovascular protection, and that data at the moment is only with semaglutide. That kind of powerful data, which actually showed. Forget all this, I won't bore you, but look at this. Risk of, these are Novo slides. The moment I tried to merge them with my slides, my presentation was going off. So I've kept them separately. So Wegovy clearly reduces the risk of MACE. So this is very important data. When you're using it in your diabetic patients, if you tell them it's going to protect your heart also, statin भी है, aspirin अगर है तो जरूरी, plus good glycemic control, good blood pressure control, plus this. So very, very important that Wegovy or semaglutide reduces our cardiovascular risk. Risk of MACE is reduced. And it is now indicated, like part of guidelines. It's an approved indication. And last is ये सब छोड़ दीजिए।
The steer trial, sir.
Essence trial में क्या है? This is the last and the newest thing. The Essence trial is about 1,200 patients with biopsy-defined NASH. Right? And we talk of this. Look at this. Semaglutide is the first and only GLP-1 RA with benefits for MASH, and it's been approved last week for management of MASLD or MASH. That's also amazing. There is no other drug that resmetirom is approved, which is hardly used or available. But none of the anti-diabetics have been approved for this. This is the first one to be approved. So improved fibrosis and NASH resolution. So quite an amazing plethora of benefits. The downsides are explained to you very clearly, but the benefits are such that if someone says, "Oh, दवाई नहीं लेनी चाहिए कुछ हो जाए," it's all, the benefits are outstanding. There is a downside. You should be aware. With every drug, you can take an aspirin and you can bleed to death. You know, anything can happen. So we should be aware. Right? We should never. This is just personal advice. Never appear to the patient to be too keen to prescribe a drug. We always give them an option and come back once you've read when you're sure. But do not give in to two things. ये तो बहुत नई दवाई है, कुछ मालूम नहीं. और दूसरा कि ये खाली वेट की दवाई है. वेट दवाई नहीं, ये वेट अपने आप कम करेंगे. ये बहुत चीज़ों की दवाई है. तो ये दो पॉइंट्स इंपॉर्टेंट है. उसके बाद पेशेंट को आप तय कर लो. डाउट है तो यू कैन मेक अप योर माइंड. So always give them a chance to make up their mind. Thank you very much. Thank you.
So thank you very much for a truly masterly presentation and covering so many of these aspects.
लाइट जला देना बेटा.
Before I just ask the opinion and the questions from my fellow panelists, just a quick question. In your practice, how do you decide between Wegovy and Mounjaro whom to give?
You pehले ही Google
लाइट जला देना.
But the thing is that we have made a policy. Till
इसको बंद
further
कर.
data appears, for all our patients with diabetes, we are using
बंद कर.
Wegovy. For those who come only for weight loss, we use tirzepatide. This is not absolute. There is switch and mix between that. शुरू में बहुत ही confusion था. So for last 1 month now, we are seriously following how to decide. So we have followed because there is more evidence on end organ involvement with semaglutide at the moment. So therefore, for people with diabetes, we use semaglutide. There is more evidence of slightly greater weight loss with tirzepatide. So those who come just for weight, we use tirzepatide.
So if a diabetic comes to you who wants more weight loss, would you still be doing this? I'm sorry, I'm pulling.
No, we offer them both. And if weight loss is the main thing, then sometimes we may change them. It's not fixed. But just a general guideline which has helped us in quickly deciding what language to use.
Thank you so much, sir. I'll hand it over to Dr. Mathur and Dr. Manish.
Thank you very much for the lovely talk. I'd like to just mention one thing about Dr. Ambrish Mithal's book, Weight Loss A Revolution. It was recently published and then, I think, given in a previous forum, I was lucky to attend one of his presentations at Gurgaon. What this book says about it? What is the role of GLP-1 agonist in the metabolic diabetes the doctor talked about? But he has given two things about it. This was very public. I felt this was with you, it is for the physician also. This book should be published to the physician also. It is very informative to everybody to learn and read about it. What we say is that weight management, we talk about lifestyle management, which we all talk to our patients, do this and do that, but it has been a failure. You have also mentioned in the book that this never works out with the patient. So try to be more practical if the weight is more than 30 BMI, everything. The drug use is very important and you should try to use whatever drug you like to use, GLP-1 or whatever it is. But you must insist about weight management, which is a very important part of it. Lastly, sir, how long do we give her, as you said, is the long-term sustained effect is very minimum after GLP-1 or even the glucagon. So should we give a lifelong as a mechanism?
So the second degree is there now. How long should it be given? So there is a certain category of patient, the overweight type 2 diabetic. When we were using GLP-1 anyway, whether we were using Victoza or Obesity or whatever, you would do it lifelong. Because someone comes to you at 55 years of age who's overweight, who has diabetes, you may moderate the dose to prevent too much weight loss. You may bring it to a lower dose. But such patients will require it for their maintenance. So that's young patients who are 25 or 30 and they are significantly obese, girls who are struggling with PCO. उनको lifelong कैसे बोलते हैं? I don't know. We don't know the answer. उनको तो कम करा के जो करा उसमें आगे देखें. So what I'm saying is that those are, it's very easy. American law सबको like obesity is a disease. It's a lifelong disease. So lifelong treatment. I am wary of using it in young patients, telling a 30-year-old कि अब तुम lifelong लीजिए.
लेकिन वेट फिर इंक्रीज हो जाता है सर.
If I say patient country,
Yes,
can use a long term, but we should initiate to give a initial first.
Yes.
Lose weight and then give patient country.
So what we are doing at the moment is we are bringing them down to a maintenance dose and keeping them there. Now those who are really good with their lifestyle and are able to maintain food diaries and everything after stopping the drug are the ones who will maintain some weight loss. Otherwise there is a tendency to put the weight back on also.
Post-bariatric surgery, they can be operated.
Yes, in fact, quite a, the bariatric surgeon is next door to me. There is a significant proportion of post-bariatric surgery weight gain patients who can be treated. Pre-bariatric surgery came to me and said, "Thoda weight come tha to surgery आसान हो जाएगी."
Lastly, I want to recommend one more thing. The book which Dr. Ambrish Mithal has written, Revolution, Weight Loss Revolution. I would like everybody to read. It is very informative. Thank you, sir.
Somebody had that book, I can just show them. I thought nobody, I don't know how
The book is here. The book is here. And I would request Mr. Sunil Yadav to please sponsor it for 70 people.
Yes, sir. I just told you that.
Who are here.
So this is the book.
This is a beautiful book.
This book is written for patients. And the idea was, yes, the idea was that these drugs were being launched, and I was reading a lot about this area of interest, and you know, it was very exciting. So when the publisher approached me, and I've been receiving so many requests from him, इस बार उसने कहा मैं सजेस्ट टॉपिक का मना नहीं करेंगे. तो मैंने कहा कि मैं कर देता हूँ. उसने कहा लेकिन आपके ये मार्च एंड, मैंने कहा मार्च एंड ठीक है, तो फरवरी 1st 2nd है ये कैसे पूरे नहीं, फिर फायदा नहीं. देन आई अंडरस्टूड द पॉइंट. लेकिन अगर इसको निकालना है तो जब ये दवाइयाँ लॉन्च हो, जब सारा कंफ्यूजन हो लोगों के दिमाग में, उसी टाइम निकालने से फायदा है. सो well, nothing comes without hard work. So 6 weeks, 8 weeks में, 6 weeks में actually ये cover to cover ये.
Dr. Manish, we would require your perspective, and then I will go to everybody. There are a lot of questions people like to answer.
So these molecules have been around, as you rightly said, since 2010, and we're finding heterogeneity amongst from the development. So with the med-influencers talking about it, something and the side effects, would that be a counterpoint with these center-acting drugs that these molecules have been there ever since, and we haven't seen a major report of
So that I definitely tell people, and that's important for us to understand, that you've been using the same class of drug for 20 years and you really haven't seen anything like this. Not in 2010, 2005. So we haven't seen it. इतना नया नहीं expect करता मैं कि कुछ आ जाएगा एकदम. Very unlikely.
So you said that for a non-responder, you designate that person who has not lost more than 5%.
Yes.
So what is the basic time frame that you're looking at before you designate as a person as
6 months to a year, achieving maximum dose.
6 months to a year.
Typically 6 months. Beginning of the business.
Right.
But having said that, there are patients who lose weight after 6 months also. Because sometimes dose titration is very difficult. People have side effects, you have to go very, very slow. So I would say 1 year is a good figure.
What is
Dr. Abha Parashar has a question.
Congratulations for a marvelous. I would just like to know you mentioned about the elderly population. So what will be the cutoff age for this elderly?
No, there's actually no defined age. It can be used in any age. But I'm just saying that many of our elderly are frail, they may have coordination issues, chronic diabetes, I'm a little wary of using it. Their muscle mass will already be low. वहाँ अगर वो elderly है, they have reached 78, 80, then क्या है? Why? What are we aiming? Let them be. Why experiment and give them, you know, that's all. That's all. So I'm scared of creating trouble for someone who is doing even moderately okay in that age.
Sir, Dr. Amitabh Gupta is a celebrated neurosurgeon at PSR.
I just want to know that the first line therapy still, when you control any kind of sugar or diabetes, is semaglutide, or in case of obesity, will you like to prescribe it as the first line, or you would like to try the traditional?
So I think that's a great question, because that's an area that is evolving right now. But almost certainly I can tell you, the moment cost becomes less and access becomes easier, SGLT2 inhibitors and GLP-1 RAs will be the first choice over metformin. It's already happening, but they will be in guidelines also as first choice. So that thing is really going to change. Sure.
So I don't know, my understanding is that metformin still works better even with kind of weight and otherwise, but yes, lifestyle modification is the most important one single thing, right?
Absolutely. No, metformin works very well. We are all brought up on metformin. But metformin, when you look at the long-term outcome data, there is no match to this. When you look at weight loss, again, there is no match to this. So, over a period of time, as people get used to it, as I said, become more accessible, maybe become oral, they will definitely replace metformin. Not replace, but they will become higher up in the pecking order than metformin.
Sir, Dr. Saurabh Mathur has a question.
Yes.
Sir, absolutely wonderful talk. Very delighted. Being a surgeon also, I felt very keen to listen to it. Sir, I have a question. Two questions basically. I recently heard that there has been lot of questions about gastric paralysis and loss of vision with using GLP-1 analogs. Is it true? And second question is, with the advent of GLP-1 analogs in our practice for management of diabetes and obesity, how do you put medical management versus balloon management versus surgical bariatric surgery management?
So I think bariatric surgery will always be there. It is the most effective way of managing obesity. But I think it will, I'm sticking my neck out here, I think it already is occupying the position which it was initially, which was for the severely obese. For all others, you know, gradually the BMI kept coming down, people said metabolic surgery, वो सब नहीं होगा. लेकिन जिनका BMI 40 है, वो तो they will be candidates for bariatric surgery. What was your first question? Yes, side effects.
There is like lot of questions in certain countries. They are withdrawing the drug on the GLP-1 analogs for loss of vision and gastric paralysis.
First, again, wrong information. It's not being withdrawn anywhere. Just last week it's been approved for MASLD. In fact, it's spreading across the world, so that is wrong. It's not being withdrawn. Number one. Number two, gastric paralysis is a reality in patients who have to undergo general anesthesia, for example. And if the patient is on GLP-1, then there is a possibility because of gastric stasis, आपने overnight fast कर दिया, that may not be enough. So it is good to stop miss a dose the week before the gastric paralysis can happen. Especially in chronic diabetics who already may have some gastric paralysis. So that is possible. The vision one I already mentioned, exceedingly there. So I was reading this thing about some billion lawsuit, some nonsense like that. So what will happen, and Novo can answer it better, most of them will be frivolous. Because what I don't understand is that how, I mean, why shouldn't the doctor, you shouldn't be asking a doctor if you're getting into trouble. Nothing as far as I know has been kept hidden. It's people who are driving their own treatment and then getting into trouble. The odd person may have a real major side effect without any warning. But most of the time, Olympic face हो गया, Olympic hand हो गया, तो रोका क्यों नहीं, बीच में कम क्यों नहीं किया? जिसने कहा था कि अगर skin sag करनी चाहिए, just reduce the dose. वो लोग आते जाते हैं. Most of it is So I don't know about the lawsuits, where they will go, but I don't think that happens with any drug that is used for everybody. The people, 20% of the American population has been exposed to the drug, 20% of the adult population. It's changing the way restaurants are serving menus. It has changed that. So what I'm saying is that the impact is so huge, it's like saying the vaccine killed many people. It really is like that. So, and you learn of some side effects later, but the fact you save millions of lives cannot be. So something like that.
Can it be used safely? Just one line. Can it be used safely in proven cirrhotic patients?
It can, but it's a bit tricky, because of GI, upper GI side. आज भी ये patient में question.
Child lay वालों में, child lay cirrhosis में.
कर सकते हैं.
Sir, Dr. Manish Gupta.
Sir, why lesser weight loss in diabetes?
Sorry,
why?
Yes, that's the subject of active research right now. The clinical parameters that have been suggested is that diabetics may be inherently more on more drugs, especially on drugs like insulin or sulfonylurea, which prevent weight loss. There may be something inherently in them which makes them diabetic. Their metabolism is slightly different, which is why they don't lose weight so easily. Some people are also suggesting that they will be more indisciplined, basically, which is why they are diabetic in that sense. So there are theories. But the one that is convincing out of the many reasons is the use of other drugs. That is definitely there.
Dr. Mathur, sir. So first, sir, I must compliment you. Your slides were, I think, very educative, not normal slides of Novo Nordisk. So very educative. Regarding Dr. Saurabh's question, can we not give this drug in patients who are very severely constipated to avoid that side effect of that?
I don't give it.
Yeah, that's.
एक दोनों जबरदस्ती लिखवा लिया and I regret it.
So the patients who are giving history of constipation, severe constipation, we should avoid.
Patients अभी बोलते हैं. So you have to be careful about what they mean by constipation. But if it is severe constipation, I would avoid.
And regarding your observation whether obesity should be mentioned as a disease or not, but we should start writing on our prescription that obesity or BMI disease.
So what I do is I use the American way of writing ABCD. ABCD is what the American Association of Clinical Endocrinologists recommends for many years. Adiposity-based chronic disease. The patient is going to have stigma. ABCD is correct, technically correct. Your team will understand. The patient will not understand that ABCD means that you are calling him a police. So it's okay.
Patient को थोड़ा समझाना भी चाहिए
Sir, Dr. Vipul Mohan, I introduced, he is a wonderful cardiologist and does the best echo in South India. He will ask you a question.
Good evening, sir. Thank you for a very informative presentation. So I have a very general, very basic question. I think on behalf of all of us who are using mono or dual receptor analog. Now you mentioned that it's always advisable to tell the patient to go to a nutritionist when you're on the therapy. A lot of us have patients who do not even bother, as you also mentioned. Do you have a hack which should just, a couple of things you jot out to the patient that this is your nutrition, what is going to look like when you're on a mono or a dual receptor. I mean, we all know telling 1 gram per kg body weight of protein and everything, but it does not work out in reality. So I just wanted your take.
So I tell them two things. Okay, I tell them that if you want to save your muscle, you jolly well save it. The second thing, if you ever want to go off the drug or plan to go off it, you better see a nutritionist. नहीं तो लगाते रह जाओ। वो लोगों को long term therapy की बात समझ में आती है। So that's the, and depending on the patient, you have to use many kinds of this thing. But these two are the ones that we commonly use. मुझे दवाई कम नहीं करनी है, जिंदगी में लगानी है, कम करनी है,
Sir, practicing diabetes for last 30 years and having been a student of Dr. Ambrish Mithal, I wanted to ask you a very frank question. We were glycemic centric maybe for the last so many decades. Is the next century is going to be only for weight and diabetes? unless we address the issue of weight, we are not doing enough for our patients.
100% right. I can't say century, but definitely the next decade or couple of decades are going to be focused on this. I have no doubt. And I just was talking to young endocrinologists at the ESICON, and I said, if you guys at this stage don't enter this field, it will be taken away by nutritionists and others, and 10 years later you will say, oh, so obesity, so you'll be left behind. If you enter this field and do a good job of clinical management, your career is made for those endocrinologists who are starting. So I definitely think that, because the reason is it's not just 2 molecules, there are many more. The field is right and shows you both for public health and for doctors, it's a good time to be there.
Sir, when we were introduced to SGLT2 inhibitors, and when we were told that there were wonderful effects on macrovascular outcomes, because UKPDS told us there were absolutely beautiful outcomes on microvascular front, and we thought, wow, we have a molecule which is bridging microvascular and the macrovascular divide. And suddenly now, sir, we are again worried about macrovascular outcomes connected with obesity and amelioration of obesity. Sir, if I am using an SGLT2 inhibitor for my patient, if I am using a DPP4 inhibitor for my patient, do I still need to, if weight is not a consideration in my patient, do I get anything beneficial by using these agents over and above SGLT2 inhibitors as far as the macrovascular outcomes are concerned?
So, studies of combinations are not enough to tell us that adding them will make a big difference, but intuitively it will. There is some anecdotal data which suggests that they will. I do think that both are very different modes of action, so I don't see why they should not be combined. I do think that in people who are, I don't generally use GLP-1s in people who are completely on the way. But I think time will change that also. I do expect that if you have high visceral fat, even if you have normal body weight, you might use very low doses of GLP-1 along with it. So SGLT inhibitors are here to stay. They are miraculous drugs. But this combination might turn out to be the best thing that you have.
Sir, you touched upon briefly about the sarcopenic aspect of using the weight loss medications. Sir, do you routinely refer all your patients who you are prescribing GLP-1 analogs to a nutritionist just to take care of the muscle loss? And we asked you a question, sir, last year about the bone loss. Dr. Tulsi sir asked you a question about bone loss. Sir, are you worried about the osteoporosis associated with these medications?
So we have reviewed the bone part a lot. The evidence is really still out. But there is no convincing preclinical or other evidence that suggests that these drugs will enhance bone loss. Anything that, as I told you, which produces major weight loss will produce some muscle loss, then the muscle bone cross-talk, loss of muscle might increase risk of falling, so indirectly it might happen. But at the moment, they are regarded as bone safe, as a drug. But you cannot, you see, any study is very difficult because you have to delineate the effect of weight loss from the drug effect. Very, very difficult to do.
Sir, just 3 messages in yes or no. Sir, Wegovy has been, 2.4 milligram has been approved for weight loss by FDA. Correct, sir?
Yes.
Number 1. Sir, Semaglutide has been approved for diabetes treatment.
Yes.
Right, sir? Right, sir. Sir, I also wanted to ask you, sir, Wegovy 2.4 milligram has been approved by FDA for MASH treatment?
Yes.
Including moderate cirrhosis?
Yes. Definitely.
The last slide that you showed. Right, so 3 messages for me. Right. Sir, Dr. Tulsi, sir.
Thank you, Dr.
Your time starts now.
So, as one would expect from such a learned speaker like Dr. Mithal, it was an astonishing talk. I learned a lot. So, just 2 or 3 small questions because of the paucity of time is already 10:40. Sir, dwell on the 2 recent studies. One published just about a week back
I'm referring to the STEER study, and the other study was the SCORE trial. Both were observational studies, but large number of patients. 30,000 patients in the SCORE trial and 20,000 patients in the STEER trial. Not to forget the Salmon 5 trial on tirzepatide. Talk us about the three trials, sir. They were all CVOT trials. Talk us about these.
I removed all the slides because that's...
I understand, sir.
But it's all right. I mean, you want to answer that? I just removed those slides at 8 p.m.
Anyway, sir, those were real world scenario patients here. And they said that increased, CV outcomes in these were, in clinical practice were very informative.
In fact, there was quite a major reduction.
Yes, the major reductions in MACE. Talk us about these two at least.
So SCORE and STEER, both are observational study, retrospective observational study, and in that, this is US-based population, as in US, Semaglutide has been launched earlier than India. So this is insurance-based data, comorbid research data which we have taken, and it is a very important data and a very stringent data. Anybody can have access. If they have money, they can buy and they can evaluate the result. So once we evaluated 10,000 patients in SEMA group, in 10,000 patients in tirzepatide group, in STEER study, we have compared and followed them for 8 months that how much MACE reduction was there, and we were able to see that when intention to treat without any withdrawal, there was 29%, with withdrawal there was 29% reduction in MACE, and per person protocol when there were withdrawals it was 57% reduction.
The key findings were the 57% reduction in MACE. See, that is very important. And my last question would be regarding, sir, the GLP-1 agonist, and we know it is very beneficial in preserved ejection fraction. So there has been some controversy regarding these agents in reduced ejection fraction. So
I've spoken about that earlier. Reduced ejection fraction studies from Spain had suggested that, but that has not been shown.
That is not?
It's not adversely impacting reduced ejection fraction.
Some studies are saying that probably aggravate, others are saying that they are neutral.
Yeah, you're right, but
I'm talking about the PRAISE and the SELECT trials, which said they are safe to use, so it doesn't aggravate. But some studies have indicated that probably it's not safe to use, may aggravate your ejection fraction.
So reduced ejection fraction was a bit controversial based on some Spanish studies, and there were some recommendations. People said that don't put all heart failure in one basket, and for GLP-1s you don't want to use it in people with reduced ejection fraction. Subsequent studies have shown that they are quite safe in that. So I think much larger studies. So I don't think there's any concern.
My last question would be regarding bone resorption. I asked in the last KV as well. So we know that PINP is a marker of bone resorption and is increased in patients who are on GLP-1 agonists. Talk us about little about the PINP.
So P1NP actually is a marker of bone formation.
Yes.
Bone formation, it's usually measured.
Marker of bone resorption. Formation? Okay.
So, but it's more easily measured than resorption markers.
Right.
That's why it is popular, because when resorption goes up, formation also goes up. There are several studies on that. It's very difficult to interpret.
The GLP-1 agonists do not have any direct effects on the muscles or on the bone. These are indirect effects because of the weight loss. That would probably also occur in patients undergoing bariatric surgery or patients who are on diet restriction, calorie restriction.
But they do have some direct impact. If at all the direct impact may be beneficial, but that is also being proven in the human context. Clinical studies assess benefits.
Talk us a little about the muscle mass loss and the lean body mass.
Oh, Alexa.
Dr. Hemant Saluja, who is a MRCP examiner, has a question.
Sir, it was a wonderful educational talk. Thank you very much. Sir, my question is that for some people, food dominates their life. And apart from after having achieved ideal weight, they would want to reduce the molecules. but the aversion to food is an apprehension that they want to verify that
Yes.
and is the gastroparesis reversible?
Yes. So the only one that I hope doesn't appear is the eye. That is still unsure. That will be a problem. But I don't think it will be serious.
Dr. Sunil Kapoor sir, my senior from Maulana, he has a question.
Sir, a very small, stupid question. That amount of weight loss was 10 kg. It must be having a component of muscle loss also.
Yes.
Yes,
So
that's
like
it.
it's like 2
Proportionate
kg,
come hai.
this thing. So then when the anti-muscle loss medicines are given, that'll get boosted up. You told us about a couple of anti-muscle loss.
Yes, that's the whole, that's one of the big areas of research.
He said about it.
So those drugs, whole class of drugs now coming up which are anti-myostatin, myostatin inhibitors, which can actually
improve muscle
mass. We'll have to see side effects. They are more to an antibody.
So that loss is minus. So that will be weight coming up to 8 instead of 10 perhaps. 10 is the total weight loss, 2 is the muscle loss, and 8 is the...
Proportionate होता है.
Right. I think we had a wonderful session. I would like to thank Dr. Ambrish Mithal sir, my moderator Dr. S Sengupta, my panelists Dr. Mathur sir and Dr. Manish, and all of you for a wonderfully conducted active participation. I would now like to ask Mr. Sunil Yadav to give a vote of thanks to all of you.